Thank you for being here this evening. I'd like to begin by acknowledging all the physicians and scholars who have sacrificed time and energy studying the issue of brain death. I would like to especially acknowledge Dr. Alan Schumann, Dr. Doyen Nguyen, and Dr. Heidi Klessig for their selfless sacrifices in this area. And I believe here tonight is a colleague, another brain death scholar, Michael Vaca. So we're very grateful that he can be here with us this evening. It's a real honor. He's back there. He's the real superstar. So you can ask him all the questions at the end of this presentation. I thank all of those who made this event possible, especially the Religious Sisters of Mercy and especially Sister Mary Sarah. The staff of the Sacred Heart Mercy Healthcare Center, and for all the people who worked to make this such a very nice time for me to be here, for being so welcoming. I'm grateful for each of you for sacrificing your time to be here this evening. And above all, I'd like to thank my wife and daughter, Jen and Tabitha. The time I spend studying, writing, and speaking about brain death is time taken away from them. Their sacrifice has made this possible. And I know that they're listening tonight, so to both of them, I love you, and I'm grateful for your support. I would like to begin with the story of Zach Dunlap. Zach is from a small town outside of Oklahoma City. In 2007, at the age of 21, he suffered a severe brain injury in an ATV accident. He was airlifted to a hospital and 36 hours later was declared brain dead. Zach had indicated on his driver's license that he wanted to be an organ donor, and his parents consented to have his organs harvested. Around this time, Zach's cousin, Dan Coffin, who was a nurse, became concerned that Zach wasn't dead. So he took Zach's foot, and he took a closed pocket knife, and he scraped it along the bottom of Zach's heel. And Zach jerked his foot away. Then he took his fingernail, and he dug it underneath Zach's fingernail in a painful way. And Zach jerked his hand away. And Dan said, "My cousin's not dead. Zach's not dead." The imminent organ harvesting was called off. So Zach narrowly survived death by organ harvesting. 5 days later, Zach opened his eyes. 12 days later, Zach took his first steps and told his parents, "I love you." 48 days later, Zach walked out of the rehab center and went home. 5 months later, Zach was being interviewed on the Today Show and Dateline. And what he said was, "I could hear the doctor declare me brain dead, but I was powerless to do anything about it." He felt angry and frustrated. Let's hear that in Zach's own words. This is Zach being interviewed.
Hospital bed, not being able to move, breathe, couldn't do anything, on a ventilator, and I heard someone say, "I'm sorry, he's brain dead, he's passing away." And there's nothing I could do. You could just get mad. I couldn't do anything to assign at all, and just kind of let it go.
Did you want to do anything?
I tried to.
What was that?
Tried to scream, tried to move, and just got extremely angry.
Yes, so it had to be a very painful time for you.
Yes, sir.
If you are an organ donor on your driver's license, this could happen to you, or your child, or your patients. People deserve to know the risks of being registered as an organ donor. People deserve informed consent, beginning at the DMV. We'll get back to Zach's story, but first, let's talk about what is death and what is brain death. We begin with the human person. The human person is the substantial union of body and soul. We have a material component, the body, and an immaterial component, the soul. We are a body-soul composite. In the Aristotelian Thomistic tradition, the soul is the life principle of each living thing. In this sense, bacteria and plants have souls just like we do. The soul is the substantial form of the body, and together they constitute the living body. The soul functions as the principle of integration of the body, making all those molecules into a unified substance or organism, which functions as a coherent whole. So what is death? Death is defined as the moment the soul leaves the body. Well, how can we know that the soul has left the body if the soul is immaterial, right? We can't see it. The same way that we know that the vital principle or soul has left an animal body by the consequences of its absence. Once the soul has left, the body begins to disintegrate, to decompose, because its principle of integration, the soul, has left. Now, of course, it does not require religion, spirituality, or philosophy to define death in a biological manner. Death manifests itself the same way in all warm-blooded mammals. So when I say, my uncle died, it means the same thing as when I say, that squirrel died. And we all know what dead animals look like. There's a long history of scientific work characterizing death as the moment when entropy overwhelms homeostasis. Death is a thermodynamic transition point, when an organism has transitioned from consuming energy and maintaining homeostasis to disintegration and decay, eventually leading to thermal and chemical equilibrium with its environment. As we will see, this biological concept of death, the irreversible cessation of the integrated functioning of the organism as a whole, is the basis for the laws defining death in the United States. Now, there are certain signs of death that have been described in human beings. First, the body cools to reach ambient temperature. Then the body stiffens, called rigor mortis. The blood drains from the surface capillaries into the deep veins, leaving the non-dependent skin gray and lifeless, and the dependent skin purplish red, called livor mortis. Eventually, putrefaction sets in. Here is a photograph of what death looks like. So that is a cadaver in the morgue. You can see the livor mortis, where the blood has drained to the dependent portion of the body. I want you to remember this because this is what death looks like. Now, look at your driver's license. You may wish to even pull it out because you may not remember. But when you got your driver's license, you chose whether or not to become an organ donor. If you chose to become an organ donor, your thought process probably went something like this. If I'm killed in a motor vehicle accident, I want to help someone else by giving them my organs. You assumed you would be truly dead. However, if you were truly dead, your organs would be decomposing. They wouldn't be good for anyone else. So what was needed was a new definition of death, and that is what we call brain death. What is brain death? In 1968, the Harvard Medical School Ad Hoc Committee defined irreversible coma as a new criterion for death. Irreversible coma as a new criterion for death. Now, you can hear that's an oxymoron. For to be in a coma is not to be dead, but to be alive. But this deeply comatose state is what we now call brain death. Brain death claims a person is dead based on loss of brain function. A brain dead patient is still warm and pink. They have supple flesh. They have a spontaneous heartbeat. They flush, sweat, and are capable of movement. Brain dead pregnant women gestate their children. In other words, apart from being in a coma, brain dead patients appear very much alive. And that's because they are alive. Today, it is widely accepted that brain dead patients are biologically living organisms. The debate has shifted into the philosophical realm. Do they count as human persons? Brain death proponents who advocate for a higher brain theory of death argue that once the capacity for consciousness and self-awareness has been lost, the human person is dead. They acknowledge that this does not correspond to the biological death of the organism, which is what 99% of the general public think of when they hear the term death. So how is someone diagnosed as brain dead? Remember, in 1968, the Harvard Medical School Ad Hoc Committee defined irreversible coma as a new criterion for death. When this occurred, there are two important things I'd like to point out to you. One, this new definition of death came into existence less than a year after the first successful heart transplant. So there is a very close temporal relationship between brain death and organ transplantation. If organ transplantation were going to be feasible, a source of fresh, viable organs was necessary. And fresh, viable organs cannot be obtained from a corpse. The second thing I'd like to point out is that the organ transplantation industry has grown to a multi-billion-dollar business. We all know that money has a tendency to distort our moral lens. I'm often asked, who makes all that money? Well, the short answer is everyone except for the organ donor. It is illegal in the United States for a person to profit from the donation of his or her organs. In contrast, organ procurement organizations profit in direct proportion to the number of organs they harvest. So they have a compelling financial interest to convince families to donate their loved ones' organs. I would say that is a conflict of interest. In fact, when organ procurement organizations perform poorly relative to others, meaning they have a lower rate of securing organ donations from potential donors as measured by the federal government, they risk losing authorization for organ procurement in their areas. So basically, they would be shut down for not harvesting enough organs. Organ procurement agents frequently use manipulative language, like, you could make your loved one's death meaningful by donating their organs. So this is a graph from 2019. So these numbers are lower than they would be today. It is the price paid by a hospital to an organ procurement organization for various body parts. So at that time, a cornea was $3,150. A small piece of the rib, $510. The ulna, $3,400, and so forth. This graph demonstrates the price paid by a patient/insurance to the hospital for the transplantation. Okay? So that same cornea that was about $3,000, for transplantation, the hospital will charge $30,200. For a heart, $1,382,400. For the liver, $812,500. My point, and this is from 2017, my point in showing you these numbers is this is big business. This is big money. All right, there is a vested interest in a lot of companies to make sure that this continues. This is an article from the Los Angeles Times from July 2023. Nonprofit that leads organ recovery in Southern California could be jeopardized by poor rankings. For decades, this nonprofit has been at the helm of a process that can mean life or death for many Southern Californians. The recovery of kidneys, livers, and other organs from deceased donors for transplants. And for years, federal regulators have deemed one legacy, that's the Organ Procurement Organization, to be falling so far short that it could eventually be shut down. Their verdict comes from a measurement system rolled out in recent years that found the nonprofit has been recovering organs from possible donors at lower rates than the majority of such organizations across the country, according to the latest report released by federal regulators. If one legacy continues to lag in the government metrics, it could lose its longtime position managing organ procurement across 7 counties in Southern California. In 2026, federal regulators are slated to begin doing something they have never done before, stripping the lowest performing agencies of their duties and offering other contractors a chance to take over their regions. This organ procurement organization would go completely out of business if they don't start harvesting more organs. Now, if that's not a compelling financial interest, I don't know what is. This slide demonstrates some of the propaganda that organ procurement organizations use. So they use these very gentle, warm pictures in order to make you feel that you're doing something good and benevolent. So you have hands holding a heart. It says, organ donors save lives. You have hands passing a paper heart. You can save a life. Did you know each of us has the power to save up to 8 lives by becoming an organ donor? Now, there's a lot of things here they're not telling you. You may be suspicious. What are they not telling me? I mean, there's these very fun, lighthearted graphics, but there's something going on behind this. We're going to discuss that. The Harvard criteria for determining brain death were as follows. A bedside clinical examination needed to demonstrate 1, a state of coma, so complete unresponsiveness to even the most painful stimuli. 2, no spontaneous muscular movements or spontaneous respirations. 3, absence of brainstem reflexes and tendon reflexes. And 4, an isoelectric EEG was strongly recommended as of great confirmatory value. In 1981, the President's Commission approved the Uniform Determination of Death Act. The Uniform Determination of Death Act serves as a model for laws passed in each individual state. Currently, all 50 states have adopted the Uniform Determination of Death Act, albeit with slight variations in the language. And it reads, as you can see, an individual who has sustained either 1, irreversible cessation of circulatory and respiratory functions, or 2, irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards. So what it's saying is that legally, you can be declared dead in one of two ways. Either the traditional way, where your heart stops, your lungs stop, and all vital function ceases, or this new way called brain death. In 1995, the American Academy of Neurology published guidelines on how to determine brain death in adults. They were last updated this month on October 11th, and today effectively serve as the accepted medical standard in the United States for diagnosing brain death in both adults and children. These are the guidelines. The title of this publication is Pediatric and Adult Brain Death / Death by Neurologic Criteria Consensus Guideline. These are similar to the Harvard guidelines and are centered around a bedside clinical examination, but these guidelines are more lax. So, for example, spontaneous movements and tendon reflexes are permitted. You can see in the methods section, it says, a panel of experts from multiple medical societies developed brain death recommendations. Because of the lack of high-quality evidence on the subject, a novel, evidence-informed consensus process was used. Well, what does that mean? That's pretty mysterious, right? So we go back to the 2010 guidelines, and they were a little more blunt. You can see on the bottom it says, it must be emphasized that this guidance is opinion-based. All right? Now, the title, when they published those guidelines, was Evidence-Based Guideline Update, Determining Brain Death in Adults. But then when you actually read it, it says, this review highlights severe limitations in the current evidence base. So you really wonder what's going on here. This article came out in August of this year. Both of these authors were also authors of the current guidelines. And what they wrote is, it is important to recognize that brain death guidelines are based on consensus opinion of expert knowledge of pathophysiology, clinical experience, and available data. As such, these guidelines are unique, because other guidelines are based on high-quality clinical evidence. We all feel very reassured. In a few minutes, I'm going to give a specific example of how this comes into play. Let's look briefly at what is required by these guidelines to diagnose brain death. There are sort of four sections to this checklist that I'm going to show you. First, there are prerequisites that must be met prior to doing a clinical examination for brain death. Second, there's components of the clinical examination, so primarily the testing of various brainstem reflexes. Third, there's performing the apnea test. And fourth, there's ancillary testing. On this first slide, we're at the prerequisites component. And what I've tried to do is underline in red to make it a little more readable, because otherwise it's a lot of words. But if we go through some of these prerequisites, so you have to ascertain that there has been a catastrophic permanent brain injury caused by an identified mechanism. Neuroimaging, so typically CT, has to be consistent with mechanism and the severity of brain injury. 3 is observation for permanency. Now, I'm going to use this one and look at letter C for illustrative purposes on how this opinion-based aspect comes into play. So letter C is for all types of brain injury other than hypoxic ischemic brain injury. And it says, a sufficient amount of time has to be waited after brain injury to ensure there is no potential for recovery of brain function as determined by the evaluator based on the pathophysiology of the brain injury. In other words, we want to make sure it's permanent, so we have to wait long enough. When you read the actual guidelines, the rationale for recommendation 9, which is cited there, is, quote, there is no evidence to support a specific observation period between brain injury of other etiologies and performance of the brain death evaluation. So there's no evidence for how long we should wait. But this determination of permanency is critical according to the rationale of the guidelines. A patient in a state of impermanent coma, apnea, and brainstem areflexia is alive. The determination of permanency is necessary before a patient in a state of coma, apnea, and brainstem areflexia can be diagnosed brain dead. And that determination, we have just learned, is based purely on someone's opinion. So phrased another way, your being alive or dead could be contingent on your healthcare provider's opinion. Additional prerequisites, you have to have a certain core body temperature, a certain blood pressure, exclusion of pharmacologic paralysis. Drug levels have to be checked, including alcohol blood levels. Exclusion of severe metabolic, acid-base, and endocrine derangements. If all the prerequisites are checked, you move on to the clinical examination. So you check for coma, and then you check various brainstem reflexes, which are listed there. After the clinical examination, the apnea test is performed. Basically, what the apnea test is you allow the carbon dioxide level in the bloodstream to increase. In theory, if the patient is dead, he or she will not begin to breathe spontaneously. Now, there's a lot of problems with the apnea test, and I'm not going to go into detail, but the apnea test poses health risks to that patient, okay? And moreover, it's not even intrinsically necessary to the logic of the guidelines themselves. So many people, myself included, would argue that the apnea test is simply an immoral procedure. It doesn't benefit the patient, right? If you were to give informed consent, you'd have to say benefits, none. Risks, it could kill you, right? Alternatives, you could not do it. And so I don't think anyone would agree to have the apnea test performed on them, but there are lots of people who argue informed consent should not be required for the apnea test. Then there's ancillary testing. The ancillary testing is, per the guidelines, not considered necessary, but can be done for certain reasons. What I'd like to point out is, so it can be conventional angiography, nuclear medicine tests, and I've underlined planar radionucleotide angiography. I did that for a reason. I want you to remember that. Transcranial Doppler ultrasound. All right, so that's sort of a quick run-through of the guidelines. I'd like to point out areas of controversy with these guidelines. 1, a diagnosis of brain death equates unresponsiveness with unconsciousness. Now, Zach's story illustrates this fallacy well. Zach was unresponsive, but he was not unconscious. He could hear the doctor declare him brain dead, but he couldn't respond. There is no reliable way in medicine to determine whether an unresponsive patient is inwardly conscious or not. Regardless of whether Zach's case is attributable to the guidelines being less than 100% foolproof or to the known variability in following the guidelines, It's an example of a serious misdiagnosis in clinical practice. The same thing that happened to Zach could happen to you, your loved ones, or your patients if you are registered to be an organ donor. Imagine how terrifying it would be if you could hear a doctor say, "You're brain dead, we're going to harvest your organs," and there was nothing you could do about it. Second, a bedside clinical examination of a comatose patient is incapable of determining the irreversible loss of all brain function. Moreover, ancillary studies allowed by the American Academy of Neurology guidelines are incapable of determining the irreversible loss of all brain function. So the guidelines cannot guarantee what the Uniform Determination of Death Act demands, the irreversible cessation of all brain function. Now, this has resulted in an ever-increasing number of lawsuits filed by families whose loved ones were declared brain dead using the American Academy of Neurology guidelines, but who were legally still alive. The third thing I'd like to point out is that spontaneous movements, including movements of the arms and legs, is considered compatible with a diagnosis of brain death. On this slide, you see all the movements that are considered compatible with brain death, according to the most recent guidelines. Spontaneous extension of the extremities, back arching, hugging, limb elevation, the thumbs up sign. So the dead person's giving us a thumbs up. I mean, that's pretty scary, right? I mean, one doesn't normally expect a corpse to give you a thumbs up. Now, I'm going to show you a video here, and in this video, the neurosurgeon is going to flex the patient's head, and when he does so, the patient's going to bring his arms up in something called the Lazarus sign. All right? Now, the neurosurgeon basically says to his resident and medical students, "Don't worry, the patient's actually dead. This is compatible with death." And you can decide for yourselves.
Vai lá. Isso. Muito bem.
Olha, isso ficou bonito, né?
Tá violento.
Do jeito que ele fez agora,
Agora abaixa os braços dele.
estimula.
É. Estimula a dor. Agora na articulação temporomandibular. Sem mexer o pescoço. Força. Mostrando que o paciente é um reflexo medular por causa da medula cervical.
Aqui também não tem.
É. Agora flete a cabeça dele. Fletindo. Isso, muito bem. Mostrando que é na medula.
Movements of brain dead patients like this one are dismissed as originating from the spinal cord and therefore of no moral significance. But anatomically, this doesn't make any sense. The brain and spinal cord are both part of the central nervous system. There are continuous neural tracts running between the two. It makes no sense to claim that once the axons pass the foramen magnum, they suddenly lose moral significance. Moreover, there's compelling evidence that movements like the Lazarus sign are mediated by the brainstem and not the spinal cord. So, for example, such movements have never been described in patients with a high spinal cord injury. And I'd like to bring to your attention here, brain-dead patients are often given anesthesia and paralytics at the time of organ harvesting. But if they were truly dead, why would they need anesthesia? If they were truly dead, they shouldn't be able to move. Why are we giving them paralytics? The final thing I'd like to note about these American Academy of Neurology guidelines is they explicitly state that persistent function of a part of the brain called the hypothalamus is compatible with a diagnosis of brain death. So this is from the new guidelines, recommendation statement 39. Clinicians may initiate a brain death evaluation and determine a patient brain dead despite evidence of neuroendocrine function, which is just a way of saying the hypothalamus. Now, this is an obvious contradiction. Part of the brain is still functioning. Therefore, by definition, the patient cannot be brain dead, as that term is used in the Uniform Determination of Death Act, which specifies all functions of the entire brain. Now, you may ask yourself, how many patients declared brain dead have persistent function of the hypothalamus? And the answer is at least half of them, and likely more than half. This is from a book chapter from the Handbook of Clinical Neurology in 2021 by Michael Nair Collins and Ari Jaffe. All told, the updated compilation includes 2,546 patients diagnosed as brain dead, of whom 1,265, or 50%, were reported to manifest central diabetes insipidus. So conversely, 50% of patients diagnosed as brain dead did not have central diabetes insipidus, which means that they had persistent hypothalamic function as indicated by persistent production of antidiuretic hormone. Same authors, same year. This is from a journal article. Moreover, up to 84% of patients declared brain dead do not develop central thyroid deficiency, and 71% do not develop central adrenal failure, showing even more false positive misdiagnoses. Brain death proponents repeat mantra-like that a diagnosis of brain death is a reliable diagnosis. What they mean by that is that if you're diagnosed as brain dead, your brain is certainly dead. This is death we're talking about, right? We don't want to mess it up. Remember that the Uniform Determination of Death Act stipulates that a diagnosis of brain death requires the complete and irreversible loss of all brain function. Therefore, according to the law of the land, at least half of patients declared brain dead in the USA are still alive when their organs are harvested, right? Because the hypothalamus is still functioning. So if we as a society were going to give informed consent to a person choosing whether to be an organ donor at the DMV, we would have to tell them, you have a 50-50 shot of being dead or alive when your organs are harvested. Now, how many people do you think are going to sign up to be an organ donor if we told them that? Right? And that's assuming that the Uniform Determination of Death Act is a valid criterion for death, which it's not. All right? All of these patients are alive. Now, I'd like to tell you another story about a patient declared brain dead. In 2013, a 13-year-old girl named Jahai McMath underwent a complex oropharyngeal surgery to address her sleep apnea. Afterward, Jahai developed excessive bleeding at the surgical site, and her condition declined. At one point, Jahai's heart stopped for 10 minutes, and 2 days later, she was declared brain dead. Now, it's very important to understand that the guidelines for a diagnosis of brain death were followed very closely in this case, all right? Every I was dotted and every T was crossed. Nonetheless, Jahai survived for 4.5 years before succumbing to abdominal complications. Most of that time, she was in her mother's apartment, supported by a ventilator and tube feedings. Videos show Jahai moving and responding appropriately to simple commands. Jahai underwent pubertal changes, including menstruation. Now, Jahai was declared brain dead using the pediatric guidelines, but was neither dead nor was she brain dead. This raises the question, how many patients like Zach and Jahai are there whose cases never come to light, either because their organs are harvested or life support is discontinued? And we don't know. The only reason Zach and Jahai survived is because their family members opposed the brain death diagnosis, refusing to allow organ harvesting. I'd like you to watch this video of Jahai and her mother.
Let's try it again. I got the video on you now, Jahai. Go ahead, move your right hand. And do it hard where people can see it. Very good, Jahai. Okay, can you move your left hand? Move your left hand, boo, where people can see it. I'm waiting. Very good. Can you move it harder? Yes. All right, girlie. And now they can't say that you can't hear your mother.
Well, they did say that. And for those of you who are parents, like me, imagine this for your child. How would you feel after watching this video if doctors were to tell you that your child was brain dead? I'm going to read the conclusion from the paper by Dr. Schumann and Salomon documenting Jahai's case. This is from their 2021 article, The Extraordinary Case of Jahai McMath. Although Jahai McMath fulfilled diagnostic criteria for brain death in December 2013, after the acute phase had passed, she manifested the hypothalamic functions of temperature regulation, menarche, and puberty, as well as the intermittent cortical functions of distinguishing her mother's voice and responding to command. The apparent relative integrity on MRI of the cortex, deep cerebral gray matter, and upper brainstem could constitute a potential structural basis for these functions. Her case represents a remarkable instance of a false positive diagnosis of brain death, made unequivocally according to the guidelines, reinforced by 4 false positive EEGs and a false positive radionuclide blood flow test. Had it not been for her mother's undaunted effort to keep her alive, the false positivity would never have come to light. Because patients diagnosed as brain dead almost always have support withdrawn or organs donated, there is no way to know the true incidence of false positivity associated with the guidelines. An unsettling conclusion with profound bioethical and policy implications. This is from their paper. On the top is Jahai's nuclear medicine scan from December 23, 2013. And what you'll see is that it demonstrated no supratentorial or infratentorial radiotracer uptake in the brain parenchyma, as indicated by the sort of blackness within the calvarium there. I've put below it a normal example using the same radiotracer. All right, and on the normal example, you can see radiotracer uptake throughout the brain parenchyma. So what this nuclear medicine scan is saying to us is that Jahai's brain is receiving no blood flow. But this is a different paper, same authors, a year later in 2022, the MRI of Jahai McMath. This MRI scan was performed September 26, 2014, approximately 9.5 months after the nuclear medicine scan. This is a single axial flare sequence at the level of the basal ganglia. Even though Jahai's nuclear medicine scan showed no evidence of blood flow to the brain, clearly on this MRI, the majority of neural tissue is preserved. Now, it may be abnormal. It may not be completely, it may have signal abnormality within it, but you see the brain. Had the brain truly not been receiving blood, as the nuclear medicine scan suggested, we would see nothing but CSF on this MRI due to encephalomalacia. So, when you have an infarct, right, what happens? Well, the brain dies and the cavity fills with fluid, all right, CSF. And so on the MRI, you don't see any brain, you just see fluid. So the nuclear medicine scan was not sensitive enough to detect the persistent low blood flow to Jahai's brain. all right? But nonetheless, despite this clearly false positive result, remember that according to the 2023 just published American Academy of Neurology guidelines, planar radionucleotide angiography is still considered an acceptable ancillary test for confirming brain death. I would like to use Jahai's case as a jumping off point for talking about chronically brain dead patients. When the Uniform Determination of Death Act came out in 1981, the rationale behind it was that the brain was the master integrator of the body, all right? It was thought that once the brain lost function, a patient would undergo cardiovascular collapse within a handful of days. However, medical evidence has proven this is not the case. By the late 1990s, over 170 cases have been collected of chronically brain-dead patients. These patients survived weeks, months, even years after a diagnosis of brain death. Instead of decomposing, brain-dead patients demonstrate a whole host of integrative functions. They maintain body temperature, pH, and electrolyte balance, fight infection, heal wounds, absorb nutrients. Chronically brain-dead patients, children demonstrate proportionate physical growth and rarely undergo sexual maturation. Brain-dead pregnant women gestate their children. This is from Dr. Schumann's 2001 paper, A Litany of Non-Brain-Mediated Somatically Integrative Functions. He goes through all the functions I just described and more. And I'm just going to go through these 3 slides very briefly just to show you this information has been around since 2001. This is not breaking news, all right? And he goes into great detail documenting this. This paper just came out from this month, 2023, Transplantation Proceedings. Suspected malignant hyperthermia in a brain-dead donor during anesthesia for organ procurement surgery, a case report. Now, malignant hyperthermia is a rare complication of certain anesthetic agents and can be fatal if not rapidly recognized. In this particular case, after induction of anesthesia, the patient's body temperature rose from a baseline of 97.5 to 98.6 degrees Fahrenheit to a maximum of 104.4 degrees Fahrenheit. Now, this little excerpt from the article reads, an 18-year-old male patient was declared brain dead from a spontaneous intracerebellar hemorrhage. He had no significant medical history or any relevant family history. Considering the extremely poor prognosis, the patient was scheduled for multiple organ donation surgery. Now, clearly, the authors and journal editors considered the donor biologically alive, referring to him as a patient, right? It's impossible for a corpse to develop malignant hyperthermia or to have an extremely poor prognosis. Nonetheless, the patient, while still alive, was scheduled for multiple organ donation surgery. So the terminology in this article illustrates the inherent contradictions that arise when talking about brain-dead patients who are undeniably biologically alive. To summarize, brain-dead patients demonstrate persistent bodily integration. They resist entropy and maintain homeostasis. For Christians and many Jews, Muslims, and Buddhists, this is consistent with the persistent presence of the soul, which means they're still alive. To quote Claude Bernard, the founder of experimental medicine, who is called by historian Bernard Cohen of Harvard University one of the greatest of all men of science, he says, when we meet a fact which contradicts a prevailing theory, we must accept the fact and abandon the theory, even when the theory is supported by great names and generally accepted. If the empirical medical evidence demonstrates that brain-dead patients are alive, we should believe our own eyes. They're alive. Now, because of the mismatch between medical practice and the Uniform Determination of Death Act, as well as for other reasons, including lawsuits that have resulted from that mismatch, a revision to the Uniform Determination of Death Act was recently proposed. The revision discards a biological concept of death and makes the current medical guidelines the law of the land. So, for example, under the proposed revision, persistent hypothalamic function would legally be considered irrelevant to being alive. Now, in fairness, under the medical guidelines, that's been the case all along, all right, and was even explicitly the case in the 1995 American Academy of Neurology guidelines. So this is not new. The proposed revision simply acknowledges medical practice in law so that they stop getting sued. And in fact, while conceptually different, the process and clinical procedures for a determination of the US-based whole brain death is essentially identical to that of the UK-based brainstem death. Thanks to the advocacy of many people, that proposed revision has been at least temporarily set aside. But it will likely resurface in the future. All right, so keep your eyes open. Despite evidence to the contrary, brain death proponents continue to claim that brain death invariably leads to systemic complications and cardiovascular collapse. So this is a slide from a CME lecture. Now, I'm giving a CME lecture. This is from a CME lecture by the Organ Procurement Organization, One Legacy, in 2021. All right, so this is what you would have heard from their presenter. Brain death leads to various systemic complications: arrhythmia, hypotension, pulmonary edema, all leading to cardiovascular collapse. This has been demonstrably false for decades. And yet, this year, in the peer-reviewed journal Neurology, Nathaniel Robbins writes, "The Uniform Determination of Death Act stipulates that all functions of the entire brain must cease for a person to be dead. The whole brain criterion is the most stringent of all potential criteria. The whole brain criterion has the advantage of the clearest biologic justification of all potential criteria. Without any functioning brain, the rest of the body will not survive long." Back to reality. We'll rely on the AP. Pig kidney works in a donated body for over a month, a step toward animal-human transplants. This is from August 2023. Surgeons transplanted a pig's kidney into a brain-dead man for over a month, and it's worked normally. A critical step toward an operation the New York team hopes to eventually try in, quote, living patients, as opposed to the brain-dead patient. The latest experiment announced Wednesday by New York University Langone Health marks the longest a pig kidney has functioned in a person, albeit a deceased person. And it's not over. Researchers are set to track the kidney's performance for a second month. So at the 2-month follow-up, New York University Langone Health released this press release. Notice the language that they use. Notice what they imply. 2-month study of a pig kidney xenotransplantation gives new hope to the future of the organ supply. I'm guessing the organ supply is not for brain-dead patients. I'm guessing it's for what they call living patients. After 61 days of observation, New York University Langone Health doctors this month completed the longest documented case of a genetically engineered pig kidney functioning in a human body. So again, they're trying to figure out how can we phrase this to not say that they're alive. The organ was removed September 13, 2023, from a 58-year-old man who had been on a ventilator with his family's consent after being declared dead by neurologic criteria before the xenotransplant. Quote, "We have learned a great deal throughout these past 2 months of close observation and analysis, and there is great reason to be hopeful for the future," said Dr. Montgomery. "None of this would have been possible without the incredible support received from the family of our deceased recipient. Thanks to them, we have been able to gain critical insight into xenotransplantation as a hopeful solution to the national organ shortage." Oh, wait a second. We just read in neurology, without any functioning brain, the rest of the body will not survive long. Well, clearly that's not true. I mean, we have evidence here that the medical establishment is keeping brain-dead patients like this one alive for the sake of transplant research because of their essentially normal physiology. How could a pig kidney function if the brain-dead patient were truly dead, right? Were a pig kidney attached to a corpse, it certainly wouldn't function. So the conclusion is the brain-dead patient's alive. Otherwise, it wouldn't be a very good test model for a living patient. While cases of chronically brain-dead patients are the exception and not the rule, that's because the diagnosis of brain death is typically a self-fulfilling prophecy. Once a person is declared brain dead, either their organs are harvested or life support is discontinued. And we don't know whether they would have survived or not. Now, at this point, my hope is that all of you can see and hear the significant difference between a corpse and a brain-dead patient. A corpse is cold, gray, and rigid. Think of that corpse that we saw in the morgue earlier. A brain-dead patient is warm and pink. They have supple flesh, a spontaneous heartbeat. Think of that young man who is being evaluated by the neurosurgeon. To claim that brain death represents death requires us to disbelieve our own eyes. Now, what is my take-home point for you? The goal of organ transplantation is to save lives, but we cannot save lives by taking life from other people, including sick or dying people. The medical evidence confirms what lay people intuitively know, and that is that brain-dead patients are alive. This quote is written by Andrew Lustig, the editor of the 2001 issue of the Journal of Medicine and Philosophy, which was dedicated entirely to brain death. So this is the editor, and he writes, "Equating brain death with loss of somatic integrative function, while useful for clinical transplant and policy purposes, is physiologically inaccurate and theoretically incoherent." 2001. This was written by Robert Trug and Franklin Miller in 2014, changing the conversation about brain death. We seek to change the conversation about brain death by highlighting the distinction between brain death as a biological concept versus brain death as a legal status. The fact that brain death does not cohere with any biologically plausible definition of death has been known for decades. Nevertheless, this fact has not threatened the acceptance of brain death as a legal status that permits individuals to be treated as if they are dead. People deserve to know the truth, that brain-dead patients are alive. According to the 2006 update to the Uniform Anatomical Gift Act, unless you have documented evidence in your medical record refusing to be an organ donor, authorized persons can make you an organ donor. Now, there's an order of preference who gets to decide. First, your healthcare power of attorney. If unavailable, your spouse. If unavailable, your adult children, and down the line. But eventually, if no one else is available, a hospital administrator can make the decision. So even if you did not choose to be an organ donor on your driver's license, you could become an organ donor without explicit refusal. I personally do not want happening to me or my loved ones what happened to Zach. So if you decide that you don't wish to be an organ donor, document it in your medical record. I also strongly suggest that you get something like this wallet card from the organization HALO, Healthcare Advocacy and Leadership Organization. What you do is you sign it, and you have 2 witnesses, you date it, you wrap it around your driver's license, and that way, if you're in a motor vehicle accident and they're pulling your wallet out to look at your driver's license to see if you're an organ donor, they cannot possibly get to it without passing through this card. All right? This is a protective mechanism. We healthcare providers have an ethical obligation to provide our patients with truly informed consent about brain death. If you found this presentation valuable, please share this information with your friends, family, and colleagues. Working together, we can push for transparency and honesty on the subject of brain death. And I thank you for your time.
I have a question. My name is Teresa Hammond. My brother was in a car accident when he was 21, and the doctors came to my parents. And this was after the accident was right in front of my parents' house, and I just happened to be there with my husband and 2 of my children. So it's really close to my heart. So when we got to the car and we realized it was him, and we were the first on the scenes, we asked him, because he wasn't breathing, we said, "Will you breathe for us? Breathe, John, breathe." We kept telling him. And every time we said, "Breathe, John," he took a breath. The doctors said that when we had asked him, they said it was very spontaneous, that it wasn't real brain function. But that never made sense to my head, ever. So when we got to the hospital, and they told my parents that they had done all the tests and that he was brain dead, it still didn't make any sense to me. And when they did the autopsy, which makes some sense to my head, they found that he had died from an severed aorta. My brain has always said, he heard me. He was alive in that car.
So these are very hard cases. I mean, they're often tragic. Without knowing the medical details of the case, I can only speak really in generalities. If a patient is breathing spontaneously, they're not brain dead, even according to the guidelines. If his condition had subsequently declined, such that perhaps they would have had to go through all the testing to declare him brain dead, and which I would be surprised if they did, given his clinical condition. But it makes an important distinction. Brain dead patients are very often dying, but they are not dead. Okay? So, for those of us who are Catholic, we believe that extraordinary care can be discontinued. All right? Extraordinary care is anything which is not ordinary care. Ordinary care means there's a reasonable hope of benefit without excessive burden or cost. Okay? Now, cashing that out specifically requires a little more, but in general, ordinary care is, reasonable hope of benefit without excessive burden or cost. Anything that does not meet that is considered extraordinary care and can be discontinued to allow a patient to die naturally. What you cannot do is kill the patient while they're dying. And that's what happens with brain death when the patient's organs are harvested. Now, I do not believe that you should allow your loved ones to undergo brain death testing irrespective of whether they plan to harvest the organs or not. Why? The reason is, as I alluded to in the presentation, is that I believe the apnea test is an inherently immoral test. It does nothing to benefit the patient and can only harm the patient. So, when you take the patient off the ventilator in the apnea test and you allow the carbon dioxide level in the bloodstream to increase, it increases the swelling in the brain. Now, when swelling in the brain increases, this will decrease the amount of blood flow that the brain is receiving. When you decrease the blood flow, the brain is getting less oxygen. So, you are basically exacerbating a pre-existing injury by doing the apnea test. It is certainly feasible that some of these patients who undergo the apnea test, like Jahai McMath, are in a state of global ischemic penumbra. What does that mean? What that means is that the brain is receiving a sufficient amount of blood to be viable but not functional. So when you get injured, your body shuts down to try and decrease the amount of energy it's using and remain alive. But it's not dead yet. Okay? So, if you have enough blood flow to maintain viability but not functionality, this is an indistinguishable mimic of brain death, both clinically and using the ancillary studies. All right? And so if you were to subject a patient in such a state who could potentially recover to the apnea test, well, now you've just tipped them over into brain death where there truly is loss of brain function that's not going to come back. So I would say, irrespective of whether they're going to harvest a patient's organs or not, whether they're considering that, you do not allow yourself or your loved ones to undergo brain death testing. All right? Does that make sense?
My name is Sister Mary Sophia. My question is, what do you think is the best solution at this point in time for patients who might benefit from, who are going through organ failure, who might benefit from an organ transplant, if that is not something that you believe is necessarily ethical to carry out?
Absolutely. It's a great question. It depends on what organ. So, kidney and liver, fairly reasonable to get those from living donors. All right? Now, there are some things like a heart which you cannot get from a living donor. In that case, there are artificial hearts. My alma mater for medical school, Duke, published a year or two ago now a paper on a guy who was almost exactly my age, who received an artificial heart. And I assume that they thought it was pretty good because they gave it to someone my age. I assume they thought it was going to last a long time. So the technology is continuing to improve on morally licit ways of providing organs. Now, it's not where it needs to be. Why? Well, because of this, right? I mean, you're getting all these organs, business is making a lot of money from it. Why would companies invest money in developing other ways to have organs? So my feeling is you cannot do that which is wrong, even if it has good consequences. So you stop doing things that are wrong, all of us do it together, and all of a sudden, money starts magically appearing to find ways that are morally okay to provide these organs. Because I am absolutely certain science can find a way. All right, 3D printing, 3D scaffolds, this stuff is amazing technology. It just requires money and energy being put into it. At this point, it's a tough decision, a very challenging decision. But I'll tell you, I've told my wife, if I'm in a serious motor vehicle accident and I need an organ transplant, if it has to come from a deceased donor, I don't get it. You let me go. Because I don't want to be complicit in it. It's a hard decision, but it's the right decision.
Hi, my name is PJ, and I want to thank everybody for everything they've done this evening and for the invitation and your speaking. Thank you so much. I have 3 questions. First of all, how do I get this off my driver's license?
With great difficulty.
Is it?
Unfortunately, yeah.
I got you.
Yeah.
Yeah.
It varies by state. I don't know exactly how you would do it in Michigan, but even if you get a new driver's license,
It's there.
You still need to get a wallet card and put it in, document it in your medical record.
So, I'm sorry to interrupt. And Dr. Eble, thank you so much. Your presentation is remarkable. Just really incredible. Thank God that the work you're doing. Talk to me after. So, in some states,
Who is me?
Michael Vaca.
Michael Vaca's back there. I told you to ask
Yeah,
him.
yeah,
I don't know why I'm up here.
And we can
No.
help you find Michael
No,
after
no.
the event
The-
if you need help.
The reason I'm bringing this up is because we're part of, and Dr. Ebel's been so kind as to correspond with me, and we've kind of corresponded on and off for a couple months. But we have a healthcare civil rights task force, and this question has come up where people want to remove the designation to be an organ donor from their driver's license. And it turns out that in some states, simply removing it from your driver's license doesn't take you off the organ donor registry. Then you have to go to the organ donor registry and you have to try to get your name removed from that registry, which turns out to be a difficult thing to do in some cases. So there are ways of trying to do that. I'm happy to help you and trying to find a solution to get that done.
Thank you. Second question is, are there any organs that can be harvested after death without the O2, without any oxygen in the blood?
So, can you obtain organs? So, if you are going to obtain an organ that is a viable organ, the patient has to be alive. All right? And so, you can, for example, take a kidney, because you have 2 of them, and you have a donor, living donor. The liver is like a beast. So like you chop the liver in half, it like hypertrophies and like grows into 2 livers. All right? And so you can take the liver from a living donor. But something that the patient cannot live without, you cannot take that from them without ending their lives. And when a patient dies, the organs truly dies, the organs quickly become non-viable. So at room temperature, it's about 5 to 7 minutes when an organ really stops to be useful for transplantation. They degrade extremely rapidly once they're taken out of the body. So that's why this whole thing was created.
Right, so like skin, you couldn't...
Skin is a tissue.
Tissue.
So organs, when I talk about organs, I mean organs like the medical definition of organ. A cornea is a tissue, okay?
Bone marrow.
Bone marrow, yes. So there are tissues that you can take. So I'm a musculoskeletal radiologist, right? Achilles tendon autografts, all right, or Achilles tendon allografts. Bone patellar bone allografts for an ACL repair, all right? These are tissues taken from cadavers because the tissues remain viable, they're fine. Not true with complex organs, okay?
Okay, last question, thank you. The new medical students, I have a grandson in medical school. What are they teaching him?
Probably the 2023 American
Exactly.
Academy of Neurology guidelines once they figure out that they were published. The problem is So we physicians are good at memorization and regurgitation, and we like checklists a lot. We really like checklists. Like if we check boxes, it makes us happy inside. Like there's a satisfaction. And so, but what we're not good at is critical analysis of the validity of something. We're not good at asking ourselves, does this make sense? Does this hold water? Children in medical school are almost, if they are taught about brain death, will almost certainly be exposed to what I've shown you. The checklist and the reassurance that if you follow the checklist, you're doing the right thing. Unfortunately, it's going to be very difficult to get this message into the upper echelons of academic medicine where it can subsequently be disseminated. There's a whole host of reasons for that. But a lot of it, as you would imagine, revolves around money, all right? So money talks. And if you want federal payments, if you're going to opt out of organ transplantation, it's going to cost you money. So I think your responsibility would be to make those who you know who are in medical school cognizant of this. They can ask for be conscientiously excused from anything involving this. And then over time, if enough people do that, then we'll begin to be able to actually reassess this. But otherwise, if they're just in medicine, yeah, they're going to get the party line.